Good morning, friends. Thanks, Dr. Krishnadas and Satyen, for giving me this opportunity. I would not only discuss what Dr. Harsh said, but I would be talking on behalf of Dr. Gauri, and then probably I would be discussing my own topic on behalf of Tanuj. So I have got 17 minutes. Harsh has taught us the clinical skill to diagnose the glaucoma. Yes, all of us knows that the diagnosis of glaucoma is very important, very critical, because we have seen lots of false positive and false negative in glaucoma. The patient who are having glaucoma are not diagnosed as a glaucoma for a very long time, and the patients who are not having glaucoma were diagnosed to have a glaucoma. So the correct measuring of the IOP, the good thorough clinical evaluation of the optic nerve, and correct measuring of the intraocular pressure is important. But all of us knows that glaucoma is not only 24 hours disease, but it's a lifetime disease. So it is highly mandatory to know the progression of disease and to know that you are treating the patients, whether your treatment is effective, because whatsoever damage glaucoma causes is always irreversible. So obviously the clinical skill is important, but the science is also equally important, because the science would tell you that whether your patient is progressing and whether your treatment is effective or not. As I said just now that we have lots of false positive and false negative, and obviously yes, if you have a good clinical skill, then at least you would be able to diagnose glaucoma appropriately. And for that, you have to measure IOP, you have to see the optic nerve head and do a thorough clinical evaluation of the retinal nerve fiber layer, do the good clinical assessment of the angle, and the standard automated perimetry is the functional test, which is highly essential and critical to diagnose the glaucoma. And you have to have the holistic approach. Just a single things out of all these cannot diagnose the glaucoma. Just on the basis of intraocular pressure, you cannot say that the patient has a glaucoma. Just on a basis of the clinical examination of the optic nerve head and the RNFL, you cannot say, because many of the patients would have a tilted disc, oblique disc, large disc, small disc, so many a times it becomes difficult, and just on the basis of the optic nerve head and the RNFL, you cannot always say that yes, this patient has a glaucoma and this patient does not have a glaucoma. Angle assessment is very critical, but you know, it has a objectivity, and I may say that this angle is open, and somebody else may say that no, it is a positional closure, and so on and so forth. So obviously for all these things, the complementary diagnostic tools are important. The functional test, I don't know, I would not say that it's a complementary, but it's an essential test for diagnosing the glaucoma and assessing the progression of glaucoma. So clinically what we say that, you know, as I said, that it's a holistic approach, and the standard definition of glaucoma is that there should be a clinical changes in the optic nerve head and the RNFL, and the correlating changes on the visual field, that is a standard automated perimetry. If your patient has this, then irrespective of intraocular pressure, you may say that yes, this patient has a glaucoma, or this patient does not have a glaucoma. The perimetry has lots of problem. All of us knows that there are performance-based errors. There are many patients who are not able to perform the perimetry well. Obviously, there is a short-term fluctuation and a long-term fluctuation, and there are several factors which affect the perimetry, that includes the media opacity and the pupil size and so on and so forth. But as I said earlier, that glaucoma is not just a diagnosis of glaucoma, but basically it is the assessment of the progression as well. And the perimetry is a very, very critical test for assessing the progression. You can see over here that over a period of time, how this patient has progressed. So obviously, if you want to prevent the needless blindness because of the glaucoma, then you have to intervene aggressively, or depending upon the perimetry result, you have to take a call that how you have to intervene. Like this patient, over a period of time, I thought that this patient has progressed, but when he underwent the cataract surgery, the fields has improved. So the perimetry would not only tell you that whether the patient is progressing or not, but would tell you again that it's really a pathological progression or the progression is because of something else. Once the cataract was removed, again the visual field has become to the normal level. And see the rate of progression in this patient. If I would not intervene aggressively for this patient, then this patient would go blind in next 3 to 5 years. So all these are very, very critical. So after the diagnosis, the appropriate diagnosis of glaucoma, you have to assess the progression. You have to see whether the therapy you have started on the patient is effective or not, and what is the rate of progression, so that you can take a call. In very advanced glaucoma, it is very, very difficult to assess the progression, and again the perimetry is a good tool. You can do the serial 10-2 analysis and you can assess the progression. That is what the glaucoma continuum, you have been seeing the slides, and I have been seeing the slide for almost more than 10 years. And Professor Weinreb has showed very categorically that the glaucoma progresses, and we are not able to pick up just by doing the perimetry alone, because when the defect appears on the perimetry, many of the patients have already lost almost 30 to 40% of the ganglion cells. So we have to pick up the glaucoma at very early stage, and for that you need to have the complementary diagnostic tool at your disposal. See this patient. So see this patient, you can see that this patient has a splinter defect over here, and there is a disc hemorrhage. Obviously, and when we did the standard automated perimetry, and this was absolutely normal, but the swab was done, and you can see that there was an early inferior arcuate scotoma which was correlating well with the disc changes. So obviously this is one of the complementary technology which was helpful, and the FDT was same. But these days we are not doing the swab and the FDT for varieties of reasons. The swab takes very long time, and the patients are not able to do well. So, and of late we are more dependent on the objective, not the objective test, not the subjective test, the objective assessment of the structural defect. And for the objective assessment of the structural defect, we have a technology at our disposal, that's an imaging technology, by which we can assess the macular area, the optic nerve head, and the RNFL in the arcuate area. So all those areas which are affected in glaucoma can be assessed by the imaging technology. You can see that, you know, how the papillomacular bundle has gone in this patient, which was picked up by the OCT and was not able to pick up by the perimetry. You can see that this was the patient where all the times the perimetry was normal, but this patient has progressed on the OCT, and subsequently we have seen that this patient has shown some changes on the standard automated perimetry as well. That is how you can pick up the glaucoma progression on the OCT-based examination, and obviously the OCT is able to pick up the glaucoma progression early as compared to the progression you can assess on the perimetry. And now there are newer tools available. You know, they are probably maybe a more complementary for diagnosis of glaucoma and assessment of its progression. One of that is the NGOCT. You can see that this is a normal disc, and you can see that the vessel density over the optic nerve head, and in the patients having a glaucoma, you can see that the vessel density, the capillary density on the optic nerve head. So all these tools may complement your diagnosis of glaucoma and may be helpful in assessing the progression of glaucoma. Similarly, the anterior segment OCT is also pretty helpful, because again, it's an objective test. There is no subjectivity involved as what is there in the gonioscopy, and other advantage is that it's a non-contact technology, and as I said that, you know, there is no objectivity is involved. And similarly, like you have a glaucoma continuum for the open angle glaucoma suggested by Professor Weinreb, you can have a glaucoma continuum for the angle closer glaucoma as well. There are various risk factors involved for the development of the angle closer glaucoma, and then subsequently the patient has an intermittent angle closer, and then going to the chronic angle closer, and then eventually goes into the blindness because it's a very fast progressive disease. So these factors which are responsible for causing the angle closure glaucoma can be best picked up by the complementary technology like the anterior segment OCT, the UBM, and the Pentacam. What are those important risk factors which otherwise we cannot pick up by doing the simple gonioscopy, or the obviously the short axial length you can pick up by just doing the biometry, the shallow anterior central depth of the anterior chamber, the decreased AC volume, the thick and more anteriorly positioned lens, and thick and voluminous iris. All these can be picked up by the anterior segment OCT. You can see that, you know, once the pupil goes in the scotopic condition, the patient who are predisposed for the angle closure glaucoma, the volume of the iris increases. So this is what we have documented, the volume of the iris increases in the scotopic condition. That is one of the risk factor for development of the angle closure glaucoma. Another important risk factor is the lens vault. If the lens vault is very steep, then these patients are likely to develop the angle closure glaucoma, and that can be picked up by doing the anterior segment OCT. Obviously, you can assess the bleb morphology by ASOCT, and as I said earlier, that the anterior chamber volume is very important, and with the Pentacam, you can measure the anterior chamber volume so that you would know that these patients may develop the angle closure glaucoma or may be at the risk of developing the angle closure glaucoma or not. The UBM is another technology which is very helpful, where some of the information you cannot gather by doing the ASOCT, you can gather by doing the UBM, particularly the condition like the Plateau iris syndrome, because the penetration of the UBM is little more posterior as compared to the anterior segment OCT. So all these hallmark feature which suggest the Plateau iris configuration of the syndrome can be picked up by doing the UBM. You can pick up the iridociliary cyst by doing the UBM. So in nutshell, the complementary technology, yes, we say that it's not easily accessible to most of the people in our country, but this complementary technology do help us in not only diagnosing the glaucoma, but also picking up the progression of glaucoma, and they have not yet become very standard, but probably it may be the future for diagnosis of glaucoma and picking up the progression of glaucoma. Thank you very much for your patience.